Okay, thank you very much for that. May we then turn to item 6 on the agenda, which is the NHS England Corporate and NHS Performance Report. Karen, I think speaking on behalf on this occasion of Richard Parker.
Yes, indeed, and I'll start on the corporate side very, very briefly. As you know, we track quite carefully and rigorously the progress of our delivery against our corporate priorities. We'll do that with this future year's business plan priorities as well. And the report reflects a January position rather than an end of March position, but we will be doing a stock take at the end of the year on how we've delivered against this year's priorities. A huge amount of progress has been made on all 10 priorities, and we'll obviously be building on that for this coming year. On the NHS performance side, as we all know, it hasn't been a particularly bad winter, and December performance was somewhat better than the year before. But in January, we've started to see the pressure emerge, and that has particularly impacted on A&E for our standard. I think it's sort of worth noting that the trend overall continues to be increased in terms of emergency admissions, but the January figures, if you compare them with last January, they look a lot higher, but that reflects a trough of performance last January versus a peak of performance, I think, this January. So the underlying trend is a lot lower, and it's only really 1.4% up compared with December. And I think that's a testament to what Simon said earlier, which is a lot of work going on at the provider level, working with commissioners as well to manage the demand side down and to ensure that that doesn't flow through into performance where we can manage it. On RTT, on the waiting time standard, again, we're very close to hitting the target, which is positive. The regions differ. So the North and Midlands and East were above target, where London, they're on or thereabouts on 92%, and only South was below target. So again, I think that's quite a good performance, which we'll obviously be trying to work with providers and NHS Improvement to try to maintain. I thought it's just also worth noting, I wasn't going to bring out much more, but worth noting the sort of continued positive progress on the mental health delivery targets on dementia and IAPT access targets as well. So I think that's continues to be a more positive story.
Well, thank you, Karen, for that report. Let me invite any comments or queries to Karen. I have Margaret and David. Margaret first.
Thank you. I've got a couple of questions, Karen, please. Can you hear me? The first one is in connection with learning disabilities. We've got a very useful measure of reduction of inpatient numbers. What would be useful would be to know whether it's possible to have a measure for the community provision, the support within, on the care side. I don't know whether that's something that you can answer now, or whether that's something that we'd need to wait for.
I think this is very much part of the plan. I'm sure Jane would want to respond on this. So, as part of the work on learning disabilities to build greater community provision, we will be wanting to find a way of measuring that. I don't think we've got that metric yet, and are not able to easily track that measure. But Jane, did you want to have more detail on that?
So as the board knows, we've got transforming care partnerships that are in place across the country, and they are combinations of commissioners, both local authority, NHS, specialised commissioning, and local providers and people, patients and carers, who are currently developing plans to deliver building the right support, which is the reduction in inpatient beds. As part of that, it will be implementing the new service model that the board has seen before, and that includes developing appropriate community services in order to be able to bring people out of hospital and stop them going in, and then subsequently reduce the number of inpatient beds. Those plans are due I think April the 8th, so we will be able to come back with a more detailed plan around each of those transforming care partnerships, which will have will show what they are expecting to do and the impact that will have. So we will be able to bring something back, but we haven't got it yet.
Thank you. And then my next question is in connection with ambulance performance, and it's really heartening to see the huge percentage that arrive within the 8 minutes, which is terrific, close to 70%. It does mean that 30% doesn't arrive within the 8 minutes. This again might be something that you need to come back on, but with regard to the 30%, do we know how close they are to the 8 minutes? If there was 40-minute hiatus, that would be pretty significant, and it would be clear that there need to be something done about that. It'd be very useful to know quite how close we are to hitting the 8 minutes with the rest of the, with those that aren't hitting that at the moment.
Right, yes. How far
Exactly.
on a more granular level? I can't answer that, I'm afraid. I don't know if anybody else can, but Bruce?
No, I can't give you an exact answer, but we can come back to you on that. My sense is it's quite close. Yeah, I'll stop there.
Thank you.
Let me then turn to David and then Michelle.
I'd like to push a bit on RTT, and I recognise that this is a shared endeavour between commissioners and providers, and therefore there's a part of this story that is absolutely about provider efficiency and provider quality. But I guess the overall trend also masks the point that Simon highlighted about elective day cases being up 4.7%, but elective inpatients down 2%. And I guess I got a number of questions, one of which is we continue to hear stories in the press about sort of the backlog of treatment and backlog of cases being growing and not being recorded. And secondly, whether a 2% fall in elective inpatients is something we should be celebrating, or actually something we should be really much more concerned about, given that this is potentially storing up more problems for 16-17. And I can't work out in my head what's going on here, and therefore I'd appreciate some insights. And I don't know whether that's you, or who's best to answer it.
Bruce, perhaps, and Simon, you might just comment.
Yeah, I'm not sure that I have a clear idea of the analysis behind that. Clearly, offsetting some of the inpatient admissions with day case surgery is important, and we do have a very clear drive to try and do that, and that's also accelerated by the advances in surgical technique and particular anaesthesia. With respect to your question about is this a kind of false reassurance that the figures are giving us, I think we'd need to come back. But my sense is it's a bit of both.
Yeah, it is, as Bruce says, a bit of both. Actually, the trend to have increases in day case elective admissions and decreases in inpatient elective admissions is a multi-year trend, and that reflects efficiencies as care that previously required a hospital stay is now being done on a day case basis. So we're seeing that continuing. In many ways that's a good thing. If you can have your gallbladder out on a day case surgery without having to have an overnight stay in hospital, for example, most people would welcome that. However, that trend is also masking something else that happened during the course of 15-16, which is not welcome, which is that for some specialties, particularly some of the more complex operations in general surgery and orthopedics, actually the capacity to deliver that was not available. and so as a result we are building up a bit of a bulge that will then spill over into pressures on the RTT waiting times targets in 16-17, and that is something that, as we come to the end of the commissioning round that Paul will discuss, is something that we're having to kind of work through on a CCG locality by locality basis in order to be able to try and get RTT to where we want it to be during the course of 16-17. And as Karen said, I mean, there are differences by specialty, there are differences by geography, particularly in the south of the country, and there are very localised differences as well. So it's pretty important that when a CCG says this is the volumes I need to procure in order to get my people fast access to planned care, that is then matched by good capacity planning on the part of local hospitals to be able to ensure that that can be fulfilled, and to the extent it looks as if it can't, then there needs to be an upfront discussion about where patients might be offered alternatives to enable them to get timely care.
And the point about press comments about sort of waiting, patients with long waiting being masked, not being recorded, and actually the problem is a lot bigger than we think it is. What's our view on that?
That's right. I think there are 9 trusts that are currently not reporting, and that, particularly in London, I think is artificially masking a set of pressures across London, and so we do need that sorted out, and NHS Improvement are working closely with those trusts on that.
Thank you. Michelle.
Hi, Karen. I'm just looking at the risk register and particularly looking at point 9. Could you talk me through the progress that has been made on specialised services, which has enabled the risk to move from amber red to amber?
So we've had a number of mitigations in place around the specialised move. They've been doing a series of reviews of particular specialised services, and let me just see what some of the other activities are. Agreeing plans for how the work can transition to new models of care, focusing on QIP, meaning efficiency delivery, so how that we can ensure that there is reduced costs and so on associated with those, and there's been a financial recovery plan, particularly in the South region as well. So there have been a number of mitigations associated with this. I think if we were assessing this now, the date where we, in January, thought we might be getting to moving to amber by March. I suspect that date is a bit further out now than we would currently assess. So this has just slipped in terms of hitting an amber. I think we're still at amber red at this stage.
Thank you.
I think it's worth just saying that the predominant risk that we were looking at here was in-year financial performance and to an extent longer-term financial performance. It is noticeable that this year the financial performance of specialised commissioning has been transformed from the biggest problem that we've had, frankly, in any of the previous years, to being one of our smallest problems. If I leave aside the Cancer Drugs Fund, which is covered by a separate risk, and which we dealt with last time indeed. So if you look at the performance of specialised commissioning, I can just give you 2 statistics. In the forecast at month 10, we've got a 7 or 8 million, I forget the exact number, I think it's 8 million variance on a budget of about 15 billion in specialised commissioning. That is light years different from the sorts of variation, volatility and frankly overspend that we've had in previous years. The second statistic is in the pack transparently that you've got for the next item, which is the QIP delivery in year in 15-16, which is running at 97% of what was viewed at the beginning of the year as a very ambitious QIP plan. Again, I just point to that as frankly a success of the specialised commissioning team who've got a grip on that in year. That is by no means to say that there isn't a big challenge going forward, of course, with some of the things we've talked about in previous meetings, the drugs pressures that are coming through, and activity growth, and trying to reduce the amount of money which is being moved into specialised commissioning on a year-by-year basis to make way for some of the other strategic things we're trying to invest in. But I think in the short term, medium term, the grip is really what's reflected in that. I don't think specialised commissioning will ever be green. I can't conceive of a circumstance in which we would say it's completely devoid of significant risk. But it does seem to me Amber is entirely justified at the moment.
And in terms of variability of quality?
Sorry.
In terms of variability of quality as well?
So that isn't the risk that this was designed to cover. It is a discussion that we can have, but I don't think there's any particular reason to believe that quality in specialised services is a particular challenge.
Okay, well, thank you very much, Karen, for that report. I invite the board to note the report and the assurance that it gives us as to our handling of corporate and NHS performance. Okay?